welcome to the first session of the Center for Health Informatics virtual speaker series. My name is Caitlin Corkin, and I am the program coordinator for the CHI team, and I will be the moderator for this event. I'd like to remind everyone to keep their microphones muted throughout the presentation. At the end, there will be a Q&A session where Dr. Grace Shen Tu will be able to answer any questions you may have. To ask your question, please either type your question in the chat box, or if your question is a little too long to type and you'd rather speak, put your hand up in the chat by maybe adding an emoji of some sort, maybe a hands up emoji, to signify that you have a question. We will proceed with the questions in order that they appear in the chat. Once it comes to your turn, I will either read the question aloud or I will unmute your mic for you to ask the question yourself. Without further ado, I'd like to welcome Dr. Grace Shen Tu, the research lead for Alberta's Tomorrow Project.
Hi, thank you for the introduction. I hope everyone can hear me. So first of all, I'd like to start by thanking the organizers for inviting me to speak in this virtual speaker series. Like Caitlin said, my name is Grace and I'm the research lead of Alberta's Tomorrow Project. And it's my pleasure to be sharing with all of you who we are and how we're supporting health research. So in this presentation, I'd like to briefly go over Alberta's Tomorrow Project's purpose and its role in health research, what we have, what we are, and the type of data that we have, as well as any of the external data that we link to that may be available for your interest, as well as some of the examples of the health research projects that we support. So I really don't need to stress this with this audience, but cancer and chronic disease are having a major impact on our population. Close to 200,000 new cases of cancer are being diagnosed every year in Canada. For Alberta alone, we would likely almost double that number by the year 2030. In Canada, 1 in 2 Canadians will have cancer at some point, and 1 in 4 will die from cancer. In addition to that, 44% of Canadians above 20 years old have at least one chronic condition, and that can include hypertension, diabetes, and COPD. 80% of the chronic conditions can be preventable, and up to 45% of cancers can also be prevented. However, in order for us to support disease prevention, we need to first understand the modifiable risk factors across these diseases. So how do these risk factors affect people independently and together? How do these risk factors affect larger populations, groups, and individuals? To answer that question, we created the Alberta's Tomorrow Project. And the project is to gain a further understanding of what differentiates those who develop disease from those who do not. What are the risks that we can define? Understanding risk factors can be quite complex. Therefore, in ATP, we took a more systematic approach where we captured not only health-related information, but all the areas that may have an impact on health. We collect demographic information, social factors, lifestyle, behavior, environment that our participants live in, as well as the health systems that they access. We know what language spoken at home. We know the household income, their education. We know about their tobacco, alcohol use. We know their personal and family health history. We know about their body size. We also ask them about their physical activity level, as well as their food choices. We try to be as comprehensive as possible with the questions we administer. All of this information has the potential of identifying risk factors and potential prevention measures. Our hope is that by collecting a wide variety of data on a large number of people and following them over a long period of time, we can answer the question of what contributes to the onset of disease. So what is Alberta's Tomorrow Project? Alberta's Tomorrow Project is a research platform and a longitudinal cohort that was created almost 20 years ago. We recruited people who were cancer-free between the ages of 35 and 69. Participants were asked to consent to provide their information, to be recontacted for follow-up, and to link their information with administrative health databases. We were able to reach a target cohort of 55,000 participants by the year 2015. Through time, some of these participants will remain disease-free, some will develop cancer, and some will have other chronic conditions. This will enable researchers to look at what differentiates those who develop disease from those who do not. Between the years of 2000 and 2008 was our first recruitment phase. We were able to recruit about 30,000 participants. During this time, we also had both the 2004 and 2005 follow-up surveys for those who have been recruited earlier on. In 2008, we joined the national cohort, which used to be called the Canadian Partnership for Tomorrow's Project and is now rebranded to Canadian Partnership for Tomorrow's Health. This provides us with the opportunity to go out and collect biosamples as well as physical measurements from participants in addition to the survey data. By 2015, we reached a total of 55,000 participants in our cohort. To collect the biosamples, which includes blood, urine, and saliva, we had a mobile team that traveled all over Alberta. The mobile unit contained all of the lab equipment necessary for sample collection, and we had a team of lab staff and project coordinators that traveled for this collection. In all of the communities we went to, we set up mobile study centers. This map gives you an idea of all the communities we visited. Some of these locations we visited more than once to increase our recruitment numbers. It was much easier for us to go to people than to expect people to come to us. This method really allowed us to have representations from rural communities in our cohort. We have blood and urine samples from approximately 30,000 participants. For those who cannot visit our physical study center, we mailed out saliva kits and collected around 10,000 saliva samples for the purpose of DNA sequencing. We also collected physical measures from around 30,000 people in our study centers. We collected standing height, sitting height, waist circumference, hip circumference, grip strength, bioelectrical impedance for body fat, resting heart rate, and blood pressure. We were able to collect our biosamples and store the samples within 2 hours, which ensures the high quality of the samples and prevents any breakdown. This is a photo of our biobank storage unit in Richmond Road Diagnostics and Treatment Center. Although we do have dedicated lab staff working with our samples, the biobank is largely maintained by the Alberta Cancer Research Biobank. Many researchers ask us how representative are we when we compare our cohort to the Alberta population. Therefore, in one of our foundational papers describing our cohort, we compared our cohort to the Alberta population breakdown. And in this diagram, you can see the breakdown by zone. We are actually quite comparable in terms of distribution, as you can see. We've also compared our cohort to the Canadian Community Health Survey data. And it's not surprising to see that we are not dissimilar from other cohorts where we have more women in our cohort. Our participants tend to be older. However, this is partially due to the fact that our recruitment criteria limited those that were between 35 and 69 at the time of recruitment. Our cohort falls in higher income categories. Higher proportion lives in urban settings. They're less likely to smoke and more likely to be overweight. This information shows that although we may not be completely representative to the Alberta population, we understand how we differ and we can adjust for it accordingly in our models. In addition to the information we collect through our survey and study center, we also conduct passive follow-up through data linkage. In ATP, we have consent from 99% of our participants to link their questionnaire information with administrative health data, such as cancer incidence, physician billing claims, drug information, and birth and death information. We also have participants' 6-digit postal codes, which can facilitate geographical mapping and linking with environmental data. Here's a diagram of the databases that we currently link to. So ATP is linked to Alberta Cancer Registry, Physician Claims Database, Pharmacy Database, as well as Alberta Precision Labs Database. We're also linked to the Alberta Cancer Research Biobank for any additional samples and tumor tissues. And we are also linked with the Canadian Urban Environmental Health Research Consortium, which provides a series of environmental data such as walkability, green space, nighttime light, and air quality, etc. And like I mentioned in above slides, we're actually part of the Canadian national cohort as well, which I'll introduce later. In the next couple of slides, I'd like to showcase some examples of how ATP data is being used for health research. For a more complete list of all approved projects, please visit our website where you'll have access to all of the approved project as well as the publication that uses our data. In ATP, we not only want to support health research, but our hope is to provide information to evidence users, such as decision makers and program planners. This is one of our projects looking at the impact of the Comprehensive Smoke-Free Places legislation, also known as the Tobacco Reduction Act, that was implemented in the province of Alberta back in January 1st, 2008. This Tobacco Reduction Act prohibited smoking in all public places, workplaces, public vehicles, and within 5 meters from doorway, windows, and air intake of workplaces or public venues. For this project, we looked at the changes in secondhand smoke exposure prevalence at workplaces as well as in homes amongst middle-aged adult non-smokers. For this study design, we looked at the secondhand smoke exposure status 1 year before the introduction of the legislation and 1 year after the implementation of the legislation. This is an infographic showcasing our results. The yellow dotted line indicates the introduction of the Tobacco Reduction Act in 2008. The left-hand column is the percentage of participants that reported secondhand smoke exposure prior to the legislation, and on the right is the percentage after the introduction of the legislation. As you can see, there was a 47% decrease in reported secondhand smoke exposure at home after the introduction of the legislation, and a 33% reduction in workplaces. This is a GIS heat map looking at secondhand smoke exposure rates before and after the introduction of the Tobacco Reduction Act. The point of this heat map is not for you to focus on any single geographical location, but rather look at the trend when compared between pre-legislation and post-legislation. You can see that there's a dramatic decrease in secondhand smoke exposure rates in the province when comparing before legislation and post-legislation. In ATP, there was also a series of research projects looking at cancer prevention behaviors. We looked at adherence to cancer prevention recommendations and the impact of adhering to those recommendations. In this series of research, we operationalized ATP data such as BMI, physical activity levels, smoking status, alcohol consumption, et cetera, based on the 2007 World Cancer Research Fund and American Institute for Cancer Research recommendations for cancer prevention. And we created a recommendation adherence score. We were able to estimate the impact of adherence on the risk of cancer. This project showed that participants who were most adherent to the recommendations were 13% less likely to develop cancer when compared to those who were least adherent. Another modifiable behavior for cancer control we've looked at was adherence to cancer screening guidelines. Regular screening following recommendations for type, timing, and frequency based on personal colorectal cancer risk contributes to earlier detection and increases likelihood of successful treatment. For this project, we looked at Albertans' adherence to screening recommendations. We divided ATP participants into those that fall into the average risk category, moderate risk, high risk, and highest risk categories. We also looked at screening patterns, which is participants' screening behavior over time. What we try to do was identify who are more likely to be a regular screener. The current Alberta recommendation for colorectal cancer screening is that anyone between the ages of 50 to 74 at average risk should be screened. If you are 40 or above with personal history of bowel condition and family history of colorectal cancer, then you should also be screened. In ATP, 77% of our participants fall within the average risk group. We have 13% with moderate risk, 8% with high risk, and 2% in the highest risk category. Only half of the average risk population in the cohort are up to date on screening. And the percentage of participants that are up to date on screening increases as the risk gets higher. We're in the highest risk category, which only accounts for 2% of our participants. More than 95% of them are up to date on screening. When looking at screening behavior over time, we have those who are regular screeners, meaning that they were up to date on screening the first time we collected information from them, and they were also up to date on screening in the follow-up. New screeners are those who were either not screened or not up to date at baseline and were up to date on screening at follow-up. Episodic screeners are those who may or may not be up to date at enrollment and was not screened at follow-up. Non-screeners are those who are not screened at both time points. And as you can see in the two graphs shown here, for both males and females, over 75% of those in the average risk group do not get screened regularly. This information is important in supporting targeted cancer screening promotion. The reasons for screening amongst those at average risk include having regular doctor checkups or have signs of physical problems. Those who are most likely to get screened are those who live in an urban area, have higher income, are retired, and are up to date on other cancer screening. Above were some examples of projects that are led by the ATP research team. ATP also supports a number of research here in Alberta and also across the country. Dr. Karen Kopshek is a senior researcher in the Cancer Epidemiology and Prevention Research Department in AHS. One of her projects is to explore individual and system factors associated with stage of cancer at diagnosis. There are differences in both individual and health system factors potentially that can affect cancer survival and mortality. At the individual level, there are health habits and comorbidities. At the health system level, there's screening, there's diagnostic delay, and there's also issues with access to care. Prediction models don't usually account for both levels of factors. In this project, we will explore the patient and system level factors associated with stage of cancer at diagnosis. The goal is to determine factors that can be used to identify individuals who may benefit from targeted screening or prevention, and thereby increasing the proportion of people diagnosed at an earlier stage. Dr. Katerina Maximova is a researcher at the University of Alberta. She's been using ATP data to look at the association between dietary factors and cancer incidence. Evidence suggests that red meat and processed meat increases cancer risk. But we all know that meat is an important source of nutrient, and we don't eat foods in isolation. Therefore, this project aims to understand the role of simultaneous exposure to food item recommended for cancer prevention. For example, red and processed meat, fruit and vegetables, and whole grains. Dr. Winston Chung, a professor at the University of Calgary, is interested in the interplay between healthcare delivery and disease outcome. Most of the time, when we think about cancer prevention, we think about those who've not been diagnosed with cancer in hopes of ensuring that they never get cancer. However, we don't really have a good understanding of the effects of early healthy lifestyle on cancer survivors. Dr. Winston Chung is using ATP data to look at whether healthy habits can help a person survive treatment for cancer by improving treatment response and avoid recurrence. There's a great quote provided by Dr. Winston Chung that I'd like to share with all of you. We can't prevent all cancers, but it would be nice to be able to tell patients one day if they're still better off through treatment and beyond because of earlier healthy habits. Like I mentioned before, ATP is also part of a national cohort called the Canadian Partnership for Tomorrow's Health, where there are over 320,000 participants across 6 cohorts and 9 provinces. We have BC Generations projects, there's Alberta's Tomorrow Project, there's the Manitoba Tomorrow Project, which is currently in recruitment mode, there's the Ontario Health Study, there's Cardigan based in Quebec, and Atlantic Path, which encompasses the Atlantic provinces. This basically translates to 1 in every 100 Canadians participate in this national cohort. The national platform supports many large projects across the country, and I'd like to give a couple of examples here. Dr. Rachel Murphy at the University of British Columbia is interested in looking at risk factors beyond smoking associated with lung cancer. As you can imagine, determining risk factors for those at average risk of developing lung cancer will require fairly large sample size. Therefore, she has requested for our national cohort data to identify other factors at play and hopefully inform lifestyle changes and strategies to prevent lung cancer. Another example that is utilizing the national cohort is a project led by Dr. Vicky Ho out of the University of Montreal. Her project is looking at occupational physical activity and lung cancer risk. We know that physical activity can reduce risk of some cancers. However, there are different types of physical activity. For example, there's workplace physical activity as well as leisure or recreational physical activity. Recreational physical activity has been shown to reduce lung cancer risk, but work-related physical activity has not been well established in this field. Some evidence have suggested that people who work a physically demanding job have a higher risk of lung cancer. In this study, the aim is to examine how lung cancer risk is associated with work-related physical activity. Before I end my presentation, I'd like to direct you to our website listed here. If you're interested in learning more about what we have, please visit www.myatpresearch.ca for a complete list of surveys administered, variables that are available. We have a complete data dictionary that's available online, as well as a list of approved projects and all of the publication that utilizes ATP data. Finally, I'd like to thank our participants, our staff, as well as our funders. What are some of the research questions we can help you answer? Thank you.
That will bring our presentation to an end. If you'd like the presentation today, we will be hosting monthly virtual events for the foreseeable future. Check out the Center for Health Informatics on Twitter to stay updated on these events. You can follow us at UCalgaryCHI. As well, if you'd like to find out more about the ATP project, you can visit their website, as Grace had said before, at www.myatp.ca, or follow them on Twitter as well at ATP Research. All right. On behalf of Dr. Shen Tu and her team, and as well on behalf of myself and the CHI team, thank you for joining us and taking the time to view the presentation. My name is Caitlin Corkin, and have a great day, and we'll see you next time.
For more information on who we are and what we offer, visit our website at coming.ucalgary.ca/CHI. If you are interested in our services, collaborating with our team, or have any other inquiries, contact us via email at chi@ucalgary.ca.